Thank you. Thank you for introduction. So first of all, why I pick up this topic? I started the clinical fellow from last July, and then I was pretty amazed you had a lot of RPLND here. So this is the institution I had a fellowship, oncology fellowship in Japan. So we had let's say bunch of the robot prostatectomy here and there, but however, we barely do the RPNND there. So this is not only in our institution. Generally speaking, in Japan, RPNND is not very common procedure. But however, here in VGH, we have 34 cases in a year. So this is we could say the 3 cases per month. And then even today, maybe Dr. Glee mentioned that we had RPLND. So just quickly review the today's case. So he's 20 years old male, and then he had a left radical orchitectomy in Egypt on October 6, 2023, the last October. And then pathology shows embryonal carcinoma with yolk sac tumor, and then he had a lymphovascular invasion as well, but a luckily negative rejection margin. And then CT scan that time shows really severe bulky retroperitoneal lymph node enlargement. And then, yeah, I will show the CT later. And then based on the imaging and the tumor markers fall into the intermediate risk category, and also clinical stage will be 2C. So he had a 4 cycle of chemotherapy, BEP, and then it completed in January 2024. So today we will do the, remove residual lymphadenopathy. So this is a CT scan. The pre-chemo, right after orchitectomy, he had a really bulky lymph node, lymphadenopathy. So not only from the left side, but also even in the paracable lymph node is kind of huge. And then this is during chemotherapy. Chemotherapy worked very well. And then now his residual tumor will be 14 millimeter here. So I'd like to review this case in the end of my presentation, and then discuss about why he needs RPLND, and then is he a candidate for nerve sparing, and then what about template for him, and then I will quickly touch on the new technology. So the question will be, this new technology will help him or not? So this is today's talk agenda. First of all, I will talk about indication of RPLND, and especially focusing on RPLND is an option for clinical stage 2 seminoma, not seminoma. The next, I'd like to present about the recommend procedure of RPLND, especially focusing on bilateral or modified unilateral template. And also, I'd like to talk about nerve sparing. And then at last, I will touch on the future direction. So microRNA as a marker, and also the possibility for robotic RPLND. So maybe everybody knows this point, but testicular cancer is relatively uncommon disease. However, it is most common solid tumor in men between young male, so between ages 20 to 34 years. And the global incidence has been slightly increasing over the past several decades. And then in Canada, 1,200 cases and 35 deaths in 2021, and which reflect excellent 5-year survival rate for this disease, almost reached to the 95%. And then testicular cancer is categorized into 2 main histological types. So as I mentioned, seminoma and non-seminoma type. Then generally speaking, non-seminoma are less common, however, more aggressive type, and then often include multiple cell types. So yeah, let's say that today's case will be non-seminoma, which contains embryonal carcinoma and also yolk sac tumor. So just quickly review the T and M staging. So I'd like to emphasize this point. So if the patient has a regional lymph node, we could say N positive disease. And then the borderline of N1, N2 will be 2 centimeter and 5 centimeter. And then regional lymph node will be this following lymph node. This is a target for RPLND. Aorta cable, which means left side of aorta, and para-aortic, the aorta cable means between IVC and aorta, and then para-aortic lymph node will be left side of aorta, and then para-cable will be right side of IVC, and then the pre and retro-aortic and retro-cable there. So generally speaking, left and right testes have differing lymph node drainage, so which means left testes go in towards the para-aortic lymph nodes, and then right side will be para-aortic cable and also the para-cable lymph node. And also this is an interesting point. So they have not only T and M, but also they have S category, which shows, the serum marker. If serum marker high, we could say S category. So this is a staging, especially, stage 1, we could say even M0, M0, they had a category for S1, I1S. And also in stage 2, based on the lymph node, the size of lymph node, we could say stage 2A, B, C, which means N1, N2, N3 disease. And then if we have, the metastasis, we could say stage 3 or more. And then I won't focusing on this point, but they have the IGCCG risk group. And then usually this risk group used for decision making for chemotherapy courses. So how many courses do they require? And then here is a testicular cancer guideline. So I check all of the guideline, AUA, NCCN, and CUA, EAU. And then these two are most updated version of guideline. So we will focusing on these two guidelines. So let's think about the clinical stage 1 seminoma. So based on the EAU guideline, they said up to 20% of clinical stage 1 seminoma patients have metastatic disease, later. And then usually retroperitoneum, which means a lymph node metastasis, and will relapse after orchidectomy alone. However, regardless of management, survival in stage 1 disease should be almost 100%. So other option will be not only surveillance, but also adjuvant carboplatin chemotherapy and also radiation might be the option for clinical stage 1 seminoma. So this is from UBC or BC cancer cohort. So what happened for the observation after clinical stage 1 testicular cancer? So they observed 2,483 cases, clinical stage 1 patient. It includes 1,100 cases of non-seminoma and also 1,300 non-seminoma patients in 1998 to 2010. So this time, I'd like to focusing on the clinical stage 1 seminoma patient. So let's say 13% patient had a relapse, had a recurrence. And then median time to relapse was 14 months, usually around 1 year after the initial orchidectomy. And then most of the relapse were observed within first 3 years. So this is a median, but usually in first 3 years, if the patient has relapse, it will happen. And then the over 1,300 cases, only one patient with clinical stage 1 seminoma died because of treatment. This isn't from non-seminoma, but died treatment-related events. And then if we're focusing on in seminoma patient, 10 years disease specific survival was 100%. So sorry for a little bit busy slide. Tiny. But as I said, 13% case after orchidectomy, clinical stage 1 seminoma patient has recurrence of lymph node. And then most of them receive the chemotherapy here. And then, 106 plus 11 would be the chemotherapy. And then 56 cases, almost 30% cases had radiation therapy. And then only one cases had RPLND after relapse of seminoma at that time. And then this is a clinical trial to compare the carboplatin versus radiation therapy for stage 1 seminoma, as adjuvant therapy. So this is a randomized trial comparing carboplatin, single dose carboplatin versus radiation therapy as adjuvant treatment for stage 1 seminoma. And then this clinical trial, they assign 1,400 patients were randomly assigned to 3:5 ratio, the carboplatin versus radiation therapy. And then recurrence-free rate at 5 years were 95% for 94.7% for carboplatin and 96.0% for radiation therapy. And then only one death as a result of seminoma in radiation therapy occurred. So based on these findings, so the effectiveness of treatment will be same in adjuvant radiation therapy and the single dose carboplatin chemotherapy as adjuvant setting for stage 1 seminoma. And then I'd like to move on to the clinical stage 2 disease, but I just quickly review TNM staging. So if the patient has between 2 centimeter to 5 centimeter lymph adenopathy, we could say N1 disease. And then if the patient has N1 disease, we could categorize the patient as stage 2A. And then if patient has sorry about that. So if the patient has 1 centimeter to 2 centimeter, we could say N1 disease, and it will be categorized as 2A. And then the patient has 2 centimeter to 5 centimeter lymphadenopathy, we could say N2 disease, and then which means stage 2B. So if the patient has clinical stage 2 seminoma, pure seminoma, what kind of option would be appropriate for the patient? So this is a EAU guideline. If patient has 2A disease, they prefer to have chemotherapy. So it's the 3 course of BEP or 4 course of EP. And then they will end up with follow-up. And then alternative option will be radiation therapy. However, they they mentioned about the RPLND for clinical stage 2 seminoma. And then they said there's no strong evidence to support the RPLND for clinical stage 2 seminoma. And then we could say in CUA guideline, the role of RPLND in stage 2 seminoma is still unclear. So this is a relatively big cohort. Retrospectively assess the clinical stage 2 seminoma case. And then, so based on the, so this is a meta-analysis case, sorry. So this case, they compare the radiation therapy versus chemotherapy for clinical stage 2A and B seminoma patients. And then in conclusion, they had so the recurrence rate in our radiation therapy in clinical stage 2B patient was 0.12, while chemotherapy patient has a little bit lower risk. So that's why they prefer chemotherapy rather than radiation therapy for clinical stage 2 seminoma case, especially stage 2B. And then, so this is a RPLND retrospective analysis. So this analysis, they're using database in US, and then they assess over 60,000 people has testicular cancer, and then almost half of them has a diagnosis with seminoma, and then 300 cases with testicular seminoma underwent primary RPLND. So they could say 5 years overall survival was 94.2, and then overall they didn't assess recurrence-free survival. So very hard to say how RPLND contribute to this number, but yeah, relatively good. However, only this retrospective analysis, we cannot say RPLND is an option for clinical stage 2 seminoma. So I'd like to discuss about the point later. So what about how about the non-seminoma case? So clinical stage 1 non-seminoma, which means there's no metastasis at the timing of orchidectomy. And then, they usually recommend to surveillance. And then if the high risk case, maybe the single dose chemotherapy will be the option, one cycle PEP. Sorry, not single dose, but the one cycle PEP will be the option for them. And then in CUA guideline, if RPLND is chosen, so that should be done in high volume facility. And then they said full bilateral template and nerve sparing technique should be better, but also I'd like to discuss about the point later. So let's go back to our cohort. I mean, as I said, so our cohort has over 1,000 non-seminoma case, I mean, clinical stage 1 seminoma case, and then 90% seminoma case had recurrence. And then most of the case, since non-seminoma is not response to the radiation therapy, most of the case received the chemotherapy here. And then, let's say almost 10% of case has RPLND. So from this analysis, we could say we could observe the patient without any treatment for clinical stage 1, even in non-seminoma patient. And then if needed, they could have chemotherapy or RPLND. And then this is the most common case for RPLND, I believe. So the clinical stage 2 non-seminoma case. So the CUA guidelines is more easy to understand. So if the patient has marker negative, maybe they could think about the RPLND before chemotherapy. And then if the patient has clinical stage 2A plus marker or above clinical stage 2B or C, actually they will have chemotherapy and then they will assess the CT scan after chemotherapy and then they will decide the patient needs chemotherapy, RPLND or not. So the primary RPLND demonstrate the relapse rate would be 10%. So the 10% case for primary RPLND as the recurrence. And then if the patient has stage 2B, I mean more than 2 centimeter lymph node, the relapse rate will be 35 to 50%. So this is maybe not appropriate approach. So that's why, if they had more than 2B case, they will recommend to have chemotherapy first, and then they will do the RPLND later. And then, so the combination will be RPLND followed by the adjuvant setting chemotherapy will be decrease the risk of relapse. So maybe this is an alternative option, but so sometimes it's kind of an over treatment for the patient. So maybe, the patient doesn't require any RPLND, but if they, set the RPLND plus adjuvant chemotherapy, maybe over treated the patient. Relapse rate after primary chemotherapy are very, very low, and then almost 4 to 9% in 2A disease, and then even 2B disease, the relapse rate will be 10, 11 to 50%. So yeah, again, so that's why, especially this case, they will do the chemotherapy first, which means almost 90% case maybe doesn't need a RPLND. So that's why we will start chemotherapy first and then consider post-chemotherapy RPLND for this case. So in summary, who is a candidate for RPLND? So for clinical stage 1 seminoma, obviously no. And then clinical stage 2 non-seminoma patient, yes. And maybe, say 2A, maybe we could think about the primary and then or post-chemotherapy if they have remaining tumor. And then most debatable situation will be clinical stage 2 seminoma. So as I said, we had a very big cohort, retrospective cohort. They said RPLND may be an option for clinical stage 2 seminoma, but there is no prospective research. So why we need to avoid radiation or chemotherapy will be, you could imagine, so the most of the case will be very young male. So they need to think about the long-term toxicity. So the toxicity from radiation and the chemotherapy will be, they will contain cardiovascular disease. Hazard ratio will be 2.4 and 2.6 in radiation therapy and chemotherapy respectively. And also it might cause metabolic syndrome and also second malignancy. So based on this point, if possible, we want to avoid this toxicity. So there's recently published 2 papers for primary RPLND for stage 2 seminoma. So this is from the Indiana University, and then this is a multi-center phase 2 clinical trial. So from UBC, our institution contribute this trial as well. So from Indiana University, they assessed 67 patients who underwent RPLND for RP only, which means retroperitoneal relapse only seminoma patient. Retroperitoneal metastasis only patient seminoma from 2014 to 2021. And then median follow-up time after RPLND was more than almost 2 years. And then 11 patients were found to have recurrence. So which means 11 patients in 67 patients has a recurrence. So which means the 2 years recurrence-free survival for RPLND only patient was 80.2%, which means 20% of case require chemotherapy or radiation therapy after relapse, after RPLND. So, but however, so which case has more high risk for recurrence? So they compare the case. So, the most worst scenario would be stage 2C. So which means stage 2C has over 5 centimeter lymph node. So maybe if the patient has over 5 centimeter lymph node, the RPLND for as a primary setting will be not the option for seminoma patient. However, if the patient has stage 1A or 2A, so the relapse rate will be the recurrence-free survival will be over 0.8, which means relatively good option for the clinical stage 2A seminoma patient. And then, interestingly, they compare the timing of relapse. So if we divide the patient as relapse has 12 months or over 12 months after orchidectomy, so we could see big difference here, the red line, the blue line. So, if the patient has relapse after 12 months of diagnosis, which means the orchidectomy, it has a lower chance of recurrence. So in conclusion from this paper, we could say stage 2C or stage 2B patient will be not a good candidate for primary RPLND. However, if the patient has stage 2A or relapse after 12 months, will be the good option. I mean, RPLND will be the good option for this patient. And then this is a phase 2 trial. So our institution also contribute to this trial. I mean, there are almost 10% of case from PGH. And then this is a phase 2 single-arm multi-institutional trial for RPLND as a first-line treatment. As I said, the primary RPLND for only for seminoma patient. And then they had a relatively strict rule for this trial. So no more than 2 lymph nodes and also 1 to 3 centimeter in size. So most of the case will be stage 2A. There's some cases stage 2B, but there's no stage 3. There's no stage 2C cases. But however, after removal, the pathology showed 3P and 3 cases. And then 1 patient received adjuvant chemotherapy, but otherwise RPLND only treatment for them. And then 12 patients experienced a recurrence. So which means 2 years recurrence-free survival will be 81%. It's very similar to this trial, but actually the more 30% of the case from Indiana University. So that's why there's some overlap between these cohorts. Anyway, so this is a survival after RPLND. So, and then especially the recurrence-free survival, we could say there's a huge difference between N1 disease and N2 disease. So N1 means clinical stage 2A, which means less than, let's say, 1 to 2 centimeter disease. And then clinical stage 2 means over 2 centimeter disease, but less than 5 centimeter. So we could say relatively good prognosis after RPLND, especially patient has N1 disease. And then this is another the cohort from German. They also doing the prospective clinical phase 2 trial for clinical stage 2A and B seminoma patient who underwent primary nerve sparing RPLND. And then, again, it shows very similar result. So almost 3 out of 30% patient developed the metastasis. So we could say after RPLND, primary RPLND for clinical stage 2 patient, we could say 80 to 90% the patient has recurrence-free survival. So yeah, again, so if the stage 2A or stage 1 with RP recurrence over 12 months cases with 1 to 2 enlarged lymph node will be the good candidate for RPLND. So yeah, I will ask some comment to Dr. Black later. And then, okay, so now we understand who needs a RPLND. So I'd like to talk about what kind of procedure of RPLND will be required. So first of all, I'd like to focusing on bilateral versus unilateral template. So as I mentioned, the regional lymph node will be paracable, intra-aorta cable, the paracable, intra-aorta cable, and also para-aortic lymph node. So the margin will be, borderline will be both, renal vascular and also ureter. So that this case, left ureter will be the border of paracable, para-aorta lymph node, and then right ureter will be the border of right side lymph node change. And then there's a modified template. So sometimes left side template might extend towards this way. So which means it contains a little bit amount of paracable lymph node. And then sometimes we could extend like this. So, but basically this is a template. So the purpose of this template would be, we could preserve nerve as well. So there's a comparison between bilateral radical resection versus unilateral template resection. So this one is not non-seminoma case, especially after post-chemotherapy, after chemotherapy. So 90 and 81 patients underwent unilateral and bilateral radical resection in this cohort. And then, so the median size of the residual mass was 7 centimeter for bilateral and 4 centimeter for unilateral template. So which means, they have very strong selection bias. They the big lymph node case require, the bilateral lymph node resection. So it will affect the result as well. The clinical stage 2 and 3 were present in 31 and 69 of patients. And then the 2 years recurrence-free survival rate was 77%, and then 72% in bilateral. So they said, the unilateral will be even better. However, they have very strong selection bias, so it's very hard to compare this case. Anyway, so they want to emphasize the point, even in the unilateral, lymph node resection is not too bad compared to bilateral lymph node dissection. And then antegrade ejaculation. This is one of the major complications after RPLND. Antegrade ejaculation was seen in 37% of the bilateral resection. And then, the antegrade ejaculation will be, the normal situation. Sorry. So, okay, we'll go back to normal after RPLND in 37% in bilateral resection, which means almost 60% of the case cannot do ejaculate antegradedly. And then, 94% of unilateral template resection group has antegrade ejaculation. However, the percentage of nerve sparing is also different from each group. So, in unilateral patient has almost 87% of nerve sparing. So, on the other hand, the bilateral template resection patient, only 45% patient has nerve sparing. So, which means, this is not fair comparison between these cases. So, anyway, so they wanted to emphasize unilateral resection will be, has the okay recurrence-free survival, and also they have very good, the preservation for antegrade ejaculation. And then another trial. This is not just single arm study, but they are doing unilateral lymph node dissection, and then after chemotherapy setting, and then most of the patient has clinical stage 2A disease, and then stage 2A and 2B disease, and then so the 5 years or 10 years recurrence-free survival rate would be 93 and 92% respectively. So, which means 90% of cases has the recurrence-free survival after post-chemotherapy RPLND in unilateral template decision. So in conclusion, we could say, if only, the selected patient, let's say clinical stage 2A or stage 2B patient, so the unilateral template would be okay. I mean, need to be considered. And then just quickly touch on the post-chemotherapy residual mass in seminoma. So based on the guideline and also this paper, we could say if the patient has over 3 centimeter mass, FDG PET scan may be considered, but the clinical relevance is not, still debatable. And then realistically, if the patient had over 3 centimeter disease after chemotherapy, and then we will do the PET scan, and then if PET scan shows positive, maybe we need to think about the RPLND. And then relapse rate after post-chemotherapy RPLND is around 12%. So, and then I'd like to talk about the nerve sparing option. So before talk about the nerve sparing, we need to know how we could coordinate ejaculation. So, there's multiple steps for ejaculation. So first of all, we need to close the bladder neck, and then seminal emission will happen, and then the sperm will come out from the penis. So this is a very very the coordinated the muscle movement there, and then so the spinal ejaculation generator triggers seminal emission, and then after reaching threshold, stimulation, orgasm or something. And then epithelial secretion by prostate and seminal vesicle controlled by parasympathetic nerve. This is a very, very lower region, so we never touch this region in RPLND. However, smooth muscle contraction of sex gland and also vas deferens and bladder neck are controlled by the lymphatic nerve here. So that's the reason why we need to think about the nerve sparing to spare the function of antegrade ejaculation. So as I said, this is exactly what we need to resect the lymph node here. So this is a border of upper border of RPLND, the renal vessel here. And then around aorta, they have the ganglion here. So from the from this ganglion, so we can see, it's rise from here, and then they make the ganglion on the anterior of aorta, and then they will have the connection towards IMA and also going toward the bottom part. So when we do the nerve sparing for paracable and intra-aortic cable nodal dissection, we need to think about between IVC and aorta, we will see this kind of nerve rising from the posterior to anterior. And then we need to recognize this nerve and then try to spare the nerve and then remove the lymph node. On the other hand, if we're doing the para-aortic node dissection, we will see the nerve from here, and then we need to think about to preserve the nerve and then remove the lymph node. So in conclusion, so in appropriately selected post-chemotherapy non-seminoma patient with clinical stage 2A and stage 2B preoperatively, after chemotherapy, the unmodified template will be, relatively good prognosis and also, less complication, especially antegrade ejaculation. So this is the last part of my presentation. I'd like to talk about the future direction. So microRNA as a tumor marker and also robotic RPLND. So recently, serum level of the microRNA is a new biomarker for testicular cancer. Since the conventional serum marker, let's say LDH, AFP, and HCG is not very sensitive. So sometimes it works, sometimes it didn't work. So that's why recently this microRNA is very promising biomarker. So this is a retrospective multi-center study to assess the effectiveness of microRNA 371. And then they collect the sample from 1,600 patients, and then 258 the normal patient cohort, normal control cohort. And then they measured up microRNA by qPCR. Okay. So for primary diagnosis of germ cell tumor, the microRNA 371 test shows sensitivity over 90% and then specificity which will be 94%. And then compared to this one, as I said, AFP, HCG, and LDH sensitivity is less than 50%. So yeah, we could say this is a better marker for primary diagnosis of GCT. And then I would say this is a level of the microRNA 371. And then, yeah, compared to control, we could say the significantly high expression in GCT, I mean, germ cell tumor, cancer tumor patient. And then if they increase the clinical stage, the level of this microRNA is increasing. So it's kind of very understandable, which means that, the clinical stage 2, stage 3 has more volume of disease. So that's why they will increase the level of microRNA. And then this is also a good thing, I think. So they could measure relapse disease. So if they have recurrent GCT, they could detected by microRNA 371. So this is a kind of promising results. We could use this marker as to monitor after therapy. However, this is a relatively new paper. It's published this year, I think. So they evaluate microRNA 371 as a predicted marker for RPLND in seminoma patient. So in conclusion, even this is a control patient, which means after resection, they confirmed pathology was negative for cancer. But and then this is a positive for cancer. If we compare the control versus seminoma, yes, we could say that if the primary setting, I mean dark dot, only one patient has negative in microRNA and then negative in pathology. But we could say the two patient is negative for microRNA but positive for pathology. But they argued, if they positive for in microRNA, the most of the case, all of the case has positive seminoma. So which means this is a kind of relatively good marker to decide if the patient needs RPLND as a primary setting. But after chemotherapy, we very hard to say. The most of the case was negative for seminoma, but some patients has still high microRNA level. So, this is not a good marker post chemotherapy. Sorry, back and forth. And then this is a really last topic for my presentation. So recently, robotic RPLND will be one of the option for very early stage of seminoma on non-seminoma disease. So this is a European Urology journal. They compared RPLND, open RPLND versus robotics RPLND. And then, yeah, they could say almost equal, sorry, the equal outcome. However, I could say there's a huge selection bias here. I mean, open approach has more big disease, and then robotic surgery has, the smaller disease. Of course, they adjust the background, but after background adjustment, yes, so they could have almost same size of disease, which means the smaller size case, maybe robotic surgery will be the option for them. Okay, so I almost up to the 1 hour, but I just quickly review today's case. So we will have this case even right after this ground round. And then, as I said, he had a 20-year-old male. he had an orchidectomy last October, and he had a clinical stage 2C disease. He had the 4-cycle BP chemotherapy. And then, so as I said, he had a clinical 2C non-seminoma patient. And then even after after chemotherapy, he had a residual lymphadenopathy. The maximum size will be 1.4 centimeter. So that's why post-chemotherapy RPLND is recommended. And then due to his age, if possible, nerve sparing should be considered. And then, but I'm just wondering, is he a candidate for modified template? Since now he has only 1.4 centimeter disease on the left side of his para-aortic lymph node. And then, yeah, so these points I don't need to ask Dr. Gleave before surgery. Anyway, so this is that's all my presentation. Yeah.